We're in Indianapolis at the third ACC Sports Cardiology Summit. And I'm with Professor of Inherited Cardiac Diseases and Sports Cardiology at St. George's University of London, Professor Sanjay Sharma. First off, thank you very much. I know you were at ESC. You made it over to this meeting with not too much time to spare. One of the first things you talked about here was the challenge of ECGs with athletes. I think as one person put it, you've got minnows looking that are actually sharks and sharks that are actually minnows. How do you deal with an athlete's ECG?
The athlete's ECG is divided into two main categories. One that reflects increased vagal tone, and the other that reflects increased chamber enlargement. And we know that about 80% of athletes would have an ECG that falls into one or both of those categories. And these changes include sinus bradycardia, sinus arrhythmia, first-degree AV block, voltage criterion for left ventricular hypertrophy, the early repolarization pattern, and incomplete right bundle branch block. I should state that these are normal changes. However, many athletes also express very profound repolarization changes that may overlap with disease processes. The current criteria for ECG interpretation are relatively conservative, and many athletes end up having false positive tests. That's the Achilles heel of the ECG.
Now, you are working on some new updated guidelines in Europe, aren't you, in ESC?
Yes, we are. We are actually in the process now of revising the 2010 ESC recommendations. It's been 5 years since we wrote them, and there has been a lot of science since then, and there are certain anomalies that we used to consider as abnormal that we would now regard as normal variants, and these include the presence of an isolated left axis deviation or right axis deviation, or even voltage criteria for right or left atrial enlargement and voltage criterion for right ventricular hypertrophy if these are found alone or in existence with other so-called group 1 ESC changes. We would consider them as normal if the athlete is asymptomatic, there is nothing to find on physical examination, and there is no family history of a sinister hereditary cardiac condition. We must also take into account ethnicity, because athletes of African American or Afro-Caribbean origin make up a very large proportion of athletes in the US for sure, and also in many European countries such as the United Kingdom and France. And these individuals do exhibit very profound repolarization changes characterized by convex ST segment elevation and asymmetric deep T-wave inversion in leads V1 to V4. Our studies have shown that these are normal variants and would not require further assessment in most athletes.
Now, what ages are we talking about? So with kids getting involved at a younger and younger age, pre-puberty, does that make a difference as to how you're looking at the ECG?
That's a good question. I think more work needs to be done on the pediatric athletes' ECG. There isn't enough data there. We need to provide some more prospective assessments. But the data that I'm alluding to is confined to athletes who are aged between 14 and 18 years old when we're talking about young people, but we extend this up to 35 years old, and you may wonder why we've capped, or why we've started, shall I say, at the age of 14 years old, and this is because most individuals by the age of 14 are in puberty, and hypertrophic cardiomyopathy, which is the most common cause of sudden cardiac death in athletes, doesn't usually show itself until puberty. So if we start before that, we may miss it. The second point is that people who are aged 14 or less express T-wave inversion in leads V1 to V3, which overlaps with the diagnosis of arrhythmogenic right ventricular cardiomyopathy. But after the age of 14, only 1 or 2% of individuals express this ECG change. So I think 14 is a reasonable age to start.
We've taken some hits from critics across the pond in terms of how we do pre-participation screening and examinations. And yet today you talked a little bit about how you do it over in Europe, and it was kind of a surprise to me. Just can you go through that? What's the difference, and are we as far behind as we sometimes are criticized for being?
Well, let's start by saying that there are two screening models which are supposed to be cost-effective or relatively cheap. The American model, which relies on history and examination, and the Italian model, which is now the European model, which relies on history examination plus the inclusion of a 12-lead ECG. Now, it's not surprising that the inclusion of a cardiac test will improve detection rate, there is no doubt about it, and therefore you're more likely to identify more athletes with disease when you include the ECG versus if you don't include it. But there are issues. Firstly, that the ECG has a very high false positive rate, and many countries do not have an infrastructure for cardiovascular screening. In fact, there are only 3 countries that actually screen all their athletes, and these are the United States, Italy, and Israel. No other country in Europe actually performs screening at mass level. In countries such as the United Kingdom and France and Spain, screening is confined to the highest echelons of sport, the most elite. It's the high school kid doesn't get screened.
And Professor Sharma's group over at St. George's in London has done a lot of the research. So go ahead and Google his name, go through PubMed. And please see the cover story in Cardiosaur's World News, where I'm Executive Editor Rick McGuire.